Welcome to the deep dive. Today, we are putting on our metaphorical scrubs and sterile gloves for a truly technical session.
Uh-huh.
We're going deep into complex orthopedic source material, focusing entirely on the surgical calculus of the hand and wrist.
Right.
This isn't a casual chat about basic anatomy. This is structured like a preoperative planning meeting or maybe an M&M conference discussion.
Yeah, exactly. Highly specific.
Highly specific, technically dense, and really focused on those intricate surgical decision pathways that, separate success from catastrophe.
That's exactly right. Our mission is to synthesize the absolute foundational knowledge necessary for hand and wrist reconstruction.
Okay.
We are zooming in from the microscopic, those precisely engineered arthroscopic portals we use to visualize the tight confines of the carpus, all the way out to the macroscopic planning required for complex tendon transfers. We need to internalize the indications, the contraindications, and the absolute mechanics
The mechanics, yeah.
of how we attempt to restore complex functions when things go profoundly wrong. We are essentially walking you through the clinical pearls you'd find in landmark texts like Campbell's Operative Orthopaedics.
The feel of this deep dive should be that of a senior surgeon mentoring a resident, focusing on the precise how-to and the deep why behind every operative plan.
Absolutely.
We need to think like engineers working with highly fragile organic machinery.
When dealing with a hand, precision is non-negotiable. It's all about the math.
Yeah.
The vectors, the amplitudes, the geometry. It really is.
Okay, let's unpack this, and we'll start small, with minimal access surgery in the wrist. It's arguably the most crowded joint in the body, right?
Oh, definitely. Full of vital structures, sensitive nerves.
So let's discuss how we safely navigate those tight confines using arthroscopy.
Right. So wrist arthroscopy. It's really transitioned from being just a diagnostic tool to an essential therapeutic workhorse now. For evaluating ligamentous injuries, checking out joint articular surfaces, identifying loose bodies. The visualization you get is simply superior.
You get that high magnification view, see things in real time.
Exactly. An unparalleled view.
And that diagnostic superiority is pretty well established. Our sources highlight that arthroscopy is demonstrably more accurate than, say, traditional arthrography for pinpointing the location and assessing the true size of injuries.
Especially for things like the TFCC.
Right, the triangular fibrocartilage complex.
And the interosseous ligaments. Arthrography might show a leak, sure, but arthroscopy shows you the lesion itself. You see the pathology.
And this diagnostic clarity has really paved the way for an ever-expanding list of therapeutic indications, hasn't it?
Absolutely. If you look at the progression, the therapeutic scope, like in box 69.1 in Campbell's, it now covers everything from debridement of localized osteochondritic lesions and synovectomy, all the way to assisted reduction and fixation of complex carpal and distal radial intra-articular fractures.
Including really tricky stuff like periluna injuries, which need perfect alignment.
Perfect alignment. That's key.
So essentially, the ability to maneuver instruments in that tiny space has opened up doors for procedures that used to require these massive open exposures.
Totally. We can now manage chronic degenerative changes, perform distal ulnar resection, the ulnar shortening osteotomy.
These little ganglion excisions.
Right, all through tiny little incisions. It's quite remarkable.
Which brings us to the cartography, the portal system. You use the analogy of the wrist as a crowded harbor, and you absolutely must know your shipping lanes. The complexity of the anatomy there with nerves, tendons, vessels, all packed in.
So close together.
Proper mapping of the wrist is like the single most important step to avoid a catastrophe, right?
Absolutely. Non-negotiable.
Okay, let's nail down that mapping then. We're referencing the standard radiocarpal and midcarpal portals, like in figure 69.15. For the radiocarpal joint, you're looking at the 1, 2, 3, 4, 4, 5, 6R, and 6U portals. What's the fundamental procedure before we even bring in the scope?
It's reconnaissance, basically. Before inserting any large instrument or the arthroscope sheath itself, we rely on mapping out the best, safest placement using fine instruments.
Like needles?
Yeah, usually 20 gauge and 22 gauge hypodermic needles. This minimizes soft tissue drag and really ensures you hit the joint capsule without skewering anything important on the way in.
And the distension technique is a classic setup pearl. Can you walk us through the geometry required? It's not just, stabbing a needle into the wrist?
No, definitely not. It's geometry, not guesswork. We typically start by locating the 3-4 portal, just distal to Lister's tubercle.
Okay.
We insert an 18-gauge needle, but here's the critical angulation you absolutely must stick to. The needle has to be inclined from dorsal distal to palmar proximal.
Palmar proximal.
Precisely 12 to 15 degrees.
Why that specific angle? What's the rationale?
It's because the distal radius naturally has that palmar tilt. If you don't angle 12 to 15 degrees palmar proximal, you risk hitting the dorsal lip of the radial joint surface instead of sliding nicely into the joint space.
Got it. Following the natural contour.
Exactly. Once the needle's placed correctly, we instill about 5 to 10 milliliters of normal saline. This fluid distension is absolutely crucial.
Why crucial?
Because it hydraulically creates the operating space. It lifts the capsule off the articular surfaces, gives you room to maneuver, and lets us safely introduce the camera without scuffing the cartilage.
Provides that hydrostatic cushioning. And speaking of safety, let's revisit that shipping lane analogy. If you deviate from the established path, say, when using the 6U portal near the ECU tendon, what are the immediate hazards? How do we prevent them?
Well, the hazards are kind of threefold. First, and maybe the most immediate worry for the patient, is fluid management.
Right, the inflow-outflow.
You have to rigorously monitor inflow and outflow pressure. If there's uncontrolled fluid extravasation into the forearm soft tissues, well, you risk a rapid onset massive forearm compartment syndrome.
Which is a surgical emergency.
Absolute emergency. Often requires immediate conversion to an open fasciotomy. You have to be vigilant.
That sounds like an issue of pressure regulation and, well, time. How long you're in there.
It is, exactly. The second hazard is nerve injury, which is just a constant threat in the wrist. When performing an arthroscopic TFCC repair, particularly through those ulnar portals, the 4, 5, or the 6U, you risk injuring the dorsal sensory branch of the ulnar nerve. We try to mitigate this by careful, minimal traction and really precise instrument placement, making sure the camera gives a crystal clear view of the structures you're approaching.
See, before you cut, essentially.
Always. And the third risk, often a silent one, is damage from the stabilization hardware itself.
Ah, like K-wires.
Exactly. We frequently use Kirschner wires, K-wires, for temporary fixation or traction during these procedures. Improper insertion, maybe too aggressive or in the wrong spot.
Risks hitting sensory nerves, especially around the portals. That can lead to persistent neuralgia after the procedure. So every step requires this mental checklist. Fluid's okay, portal trajectory good, where's the nerve? What about the distal radio-nor joint portals, the DRUJ portals? They seem particularly high risk, given how packed everything is near the ulnar head.
They are inherently high risk, yeah. We typically use a proximal DRUJ portal and a distal one.
Okay.
When accessing the proximal portal, the critical structure you have to avoid is the posterior interosseous nerve, the pin. It runs deep and proximal to the extensor retinaculum.
So a slip there.
Slip of the instrument too far proximally, and you can end up with a pin palsy. Not good.
And a distal portal.
Conversely, when inserting instruments through the distal DRUJ portal, the TFCC itself is actually at risk of being damaged by the entry instrument. You could undermine the very stability you might be trying to assess or repair.
So the bottom line rule remains: meticulous knowledge of wrist anatomy and strict adherence to correct established technique. That's the only thing that truly mitigates these significant procedural complications.
100%. If you don't know the map, you shouldn't sail the ship. Simple as that.
Okay, let's transition now from ligament instability to bony compromise, focusing on the scaphoid. This is maybe the most frustrating bone in the body.
Oh, tell me about it.
Due to its precarious blood supply and that high rate of misdiagnosis.
The scaphoid is orthopedics' favorite tightrope walk, as you put it. For acute, non-displaced, stable fractures, the historical controversy over non-operative treatment. It still persists.
Yeah, we spend conference time debating short versus long arm thumb spica casts.
Wrist position, slight flexion, or slight extension.
But why the continued debate if the literature, the meta-analyses seem to show non-inferiority? They indicate no significant differences in union rate, pain, grip strength, or time to union across various non-operative methods. Why not just cast everyone?
That's where the clinical nuance comes in, right? The insight, which the source material often implies but doesn't always spell out explicitly.
Okay.
While the overall union rate might look similar on paper, the clinical preference often leans towards surgery because of two things: predictability and patient compliance or efficiency. Well, experimental data, which we referenced, show that even a fracture that looks stable, even in a good cast, can still displace more than 3 millimeters during simple pronation or supination.
Wow. So even stable isn't truly static.
Not really, no. So surgeons trend toward earlier operative fixation, often percutaneous screw fixation. Not just because non-operative fails more often, necessarily, but because surgical fixation gives you predictable, rigid internal fixation.
Which means?
So it means earlier mobilization of the fingers, less stiffness, and a faster return to function, even if the overall time to solid bony union is statistically similar in the end.
That makes sense. For the working patient or anyone active, that efficiency often trumps waiting 12-16 weeks stuck in a cast.
Exactly. Time is function.
So what are the key risk factors that immediately push us toward operative fixation, especially when dealing with a delayed diagnosis?
Delayed diagnosis is the single biggest culprit. Estimates suggest up to 40% of scaphoid fractures are initially missed, written off as just a sprain.
40%? That's huge.
It is. Other major factors are gross displacement, any associated ligamentous injuries, and critically impaired blood supply to the proximal pole. That's the killer.
And the data backs that up.
Yeah, we see in the MAC et al. Study that middle third fractures diagnosed late, like 6 months late, needed an average of 19 weeks to heal. Compare that to just 10 weeks for acutely diagnosed similar injuries.
So almost double the time.
Pretty much. The longer you wait, the more fibrous tissue infiltrates the fracture site, the blood supply gets worse. It's a downward spiral.
Okay, so if we move to percutaneous fixation, which is the established modern trend, imaging is paramount. What are the absolute non-negotiable technical steps under fluoro?
The goal is central axis placement of the guide wire. That's everything.
How do you achieve that?
You have to get perfect scaphoid alignment first. This involves carefully pronating and flexing the wrist until the scaphoid poles line up perfectly to get that characteristic ring appearance on fluoroscopy. You see it in figure 69.26.
That ring needs to be perfectly round, right? Confirms alignment in both planes.
Perfect circle. Confirms alignment AP and lateral. That alignment gives you your target.
Okay.
Once you see that ring, the guide wire must be inserted precisely down the central axis of the scaphoid. Dead center.
What happens if you're off? It's eccentric.
If you're eccentric, off the dead center, you risk either fracturing one of the poles as the screw goes in, or ending up with hardware prominence that causes painful impingement later, like in figure 69.27.
It's a precise game of anatomical billiards, then.
Exactly what it is. You have one shot to get it right.
Now let's fast forward. The patient is years out from a failed non-union, often complicated by osteonecrosis, especially in that proximal third.
Which has a 30% to 40% incidence of AVN.
Right. So what is the cascading disaster we start to see on imaging then?
The disaster is the collapse pattern. It's what we call SNEAS wrist scaphoid non-union advanced collapse.
Yeah.
You see it illustrated in figure 69.33.
Okay, SNEAS wrist.
The collapse starts because the proximal fragment, lacking blood supply and structural support, collapses downward and rotates into what we call dorsal intercalated segment instability, or DISA.
DISA.
This leads to progressive arthritis, starting with radioscaphoid narrowing, then capital lunate narrowing. It's a predictable pattern.
What's the key clinical insight about SNSC versus, say, SLAC wrist scapholinate advanced collapse?
The key insight, and this is a major determinant for salvage options, is that in early SNAC, the radiolunate joint is typically spared.
Why is that?
Because the lunate usually stays tethered to the trochetrum and the capitate.
Yeah.
This sparing gives us a window, a chance for motion-preserving salvage procedures.
Okay, so what is the spectrum of salvage operations we consider based on how bad the arthrosis is?
Well, if the disease is early and primarily focused on the non-union site itself, we might attempt reconstruction with bone grafting.
Vascularized or non-vascularized?
That decision is heavily influenced by MRI findings showing if the proximal pole is still viable, or by actually looking at it intraoperatively, does it bleed? If it bleeds, maybe non-vascularized is okay. If it's dead, you need vascularized graft.
But if the arthritis has really set in, if those joints are shot...
Then we move to joint alteration procedures. We can consider a proximal row carpectomy, or PRC.
PRC, removing the proximal row.
Exactly. You remove the scaphoid lunate and trichotrum, the whole proximal row. It's a powerful, motion-preserving alternative to a total wrist fusion.
Yes.
If the articular surface of the capitate head and the lunate fossa of the radius are still in good shape, well preserved.
Then who's a candidate for that?
It's usually reserved for lower demand patients who can tolerate maybe minimal persistent pain, but really want to avoid a total fusion. They accept a trade-off.
And if even the capitate head or lunate fossa are gone, then we're talking fusion, partial or total.
Yes. For conditions like rotary subluxation of the scaphoid that hasn't yet led to severe pancarpal arthritis, maybe a Trescap arthrodesis.
Using staphoid, trapezium, trapezoid.
Right. That can stabilize the radial column while preserving some wrist motion. But the decision is always that trade-off. Motion versus stability and pain relief. What does the patient need most?
Let's pivot slightly to another avascular necrosis challenge. Kienbock disease, the osteonecrosis of the lunae. How does our approach differ here compared to scaphoid AVN?
Treatment for Kienbock disease is completely stratified by the Lichtman classification. That's in Table E69.2.
Okay, Lichtman stages.
This staging system dictates the entire approach based on the radiographic findings. Stage 1 is just sclerosis, 2 it involves fragmentation, 3 shows fixed rotation and collapse, and 4 means adjacent joint degeneration, usually radiocarpal arthritis. We don't guess, we stage, and we treat based on that stage.
And the core concept for earlier stage treatment is often a joint leveling procedure, right?
Exactly. The central hypothesis, though still debated a bit, is that abnormal loading contributes to lunate failure. Often this is driven by ulnar negative variants.
Meaning the ulna is shorter than the radius at the wrist.
Correct. So for stage I, or maybe early ICLIA cases with ulnar negative variants, we aim to equalize the load across the wrist. We do this by performing either an ulnar lengthening osteotomy or a radial shortening osteotomy.
It requires stunning geometrical precision. I remember the sources providing hard data on the biomechanical impact of these leveling procedures.
This is where the engineering aspect gets really fascinating. Biomechanical analysis has actually shown that doing a radial closing wedge osteotomy, for instance, it doesn't just look better on an X-ray. It statistically and significantly decreases the force transmitted across the wrist.
How much?
Specifically, it decreases the force on the lunocapitate joint by about 23%, and even more dramatically, on the ulnalinate joint by 36%.
36%. That's high-stakes arithmetic. It means the surgeon has to calculate the exact degree of shortening or angulation needed to achieve those calculated force shifts. A millimeter off could negate that benefit.
Precisely. The osteotomy must be planned meticulously preoperatively, often using templates, to ensure the new geometry effectively offloads that sick lunate.
And for later stages, stage IVA with ulnar neutral variants, or IA where collapse is happening.
For staged IA, ulnar neutral, maybe a radial wedge osteotomy or an STT fusion. But for later stages, IAA and particularly IAB, where fixed carpal collapse is imminent or occurring, the trend is moving toward complex revascularization procedures.
Like the flap you mentioned.
Yeah, we introduced the medial femoral condyle ospichondral free flap. This is a microvascular procedure. We bring a new living piece of bone and cartilage with its own blood supply via microsurgery from the knee into the collapsed lunate space. The hope is to halt further progressive carpal instability.
Wow. That's a massive resource-intensive solution for a devastating problem.
It really is. But it can save the wrist from fusion in some cases.
That brings us neatly from the fixed, bony support structure to the dynamic engines of the hand, the muscle tendon units.
Right. So if hand reconstruction is orthopedic engineering, then tendon transfer planning is the ultimate logistics challenge.
Logistics challenge, I like that.
You're essentially replacing a paralyzed engine with a healthy, expendable one, but the success is entirely constrained by biomechanical reality. You can't cheat physics.
And we absolutely must first address the foundational principle: stability. A powerful tendon transfer going to a joint that lacks stability is just a wasted effort, right?
Completely wasted. The joints must be dynamically stabilized or stabilized passively, maybe via arthrodesis or a tenodesis, before you hook up the new motor.
Classic example being thumb opposition.
Perfect example. Restoring effective opposition to the thumb. The thumb carpometacarpal joint, the CMC joint, must be dynamically stabilized but still freely movable to provide a stable base for pinch. If the thumb just collapses under load, the transfer fails functionally, even if the tendon pulls perfectly.
Okay, let's talk logistics, the motor selection itself. We need a muscle that is extrinsic, expendable, and healthy. But the most critical constraint seems to be amplitude.
Amplitude, yes, the actual excursion potential of the tendon.
You can't ask a small cable to pull a heavy load over a long distance.
That's the entire equation summarized beautifully in Table 71.1, which details the amplitude of excursion. This table is basically your Bible for planning these things.
And the differences are huge.
Oh yeah, look at the disparities. The flexor digitorum profundus, the FDP, has this massive 70 millimeters of excursion potential.
70?
Whereas the common finger extensors, the EDC, only offer about 50 millimeters. And a wrist motor, like the extensor carpi radialis longus, ECRL, gives you maybe 33 millimeters.
So if the function you're trying to restore needs, say, 60 millimeters of movement, and you only transfer a 33 millimeter motor, You've failed before you even tie the knot.
You have.
Yeah.
Game over. You absolutely must ensure the new motor has sufficient amplitude and strength to reach the destination and perform the required job. It's like trying to tow a boat with a bicycle chain.
Right. The strength might technically be there, but the length and efficiency are all wrong.
Exactly. And the direction, the routing of the transfer, also has to mimic the paralyzed muscle's vector as closely as possible. You want to minimize the need for pulleys. We're creating new friction points. Smooth gliding is key.
Okay, let's apply these critical principles to some specific nerve injury patterns, starting with radial nerve palsy. We need to distinguish between high and low lesions, right?
Absolutely critical distinction. High radial nerve palsy, typically from something like a humeral shaft fracture, is functionally devastating.
Why so bad?
The patient loses wrist extension, finger MP joint extension, and thumb extension abduction. The absolute loss of wrist extension is the key here.
Right.
Without a stable, extended wrist, the flexor tendons are essentially flaccid.
They lose their optimal length tension.
Precisely. They can't generate effective grip force. The hand becomes essentially useless for powerful grasp, even though the flexor muscles themselves are perfectly fine.
That contrasts sharply with the low radial nerve palsy, often involving the posterior interosseous nerve, the Pishin, which branches off more distally.
Right. In a pin palsy or low radial palsy, the main wrist extensors, specifically the ECRL and usually the ECRB, are preserved because they're innervated higher up.
So wrist extension is intact.
Wrist extension is intact, but often deviates radially because the ECU is out. But the patient lacks independent finger and thumb extension. The functional impairment is that they can't open their hand fully or position the digits effectively to release objects. You get that striking finger drop or wrist drop deformity, even though they can extend the wrist itself.
Got it. Moving medially, let's look at the ulnar nerve palsy. Here, too, the differentiation between high and low is crucial, especially for motor selection.
Extremely important, yeah, because of what you lose proximally in a high lesion. A low ulnar palsy affects only the intrinsics, the small muscles within the hand.
Leading to the classic clawing.
Exactly, the classic claw hand deformity. Hyperextension of the MP joints and flexion of the IPs, especially in the ring and little fingers. But in a high ulnar injury, proximal to the elbow, you lose the intrinsics plus critical extrinsic power. Specifically, the flexor digitorum profundus to the ring and little fingers, and the flexor carpi ulnaris, the FCU wrist flexor ulnar deviator.
And the clinical implication of losing the FDP and FCU for transfers.
It means you lose the ability to use the ring finger flexor digitorum superficialis, the FDS, as a motor for intrinsic reconstruction.
Because the ring FDS is often a go-to motor in low ulnar palsy.
It's often the perfect motor in a low palsy. Good amplitude, expendable. But in a high palsy, the ulnar nerve motor power to it is gone. So you must select a different motor source, often something more powerful innervated by the radial or median nerve, like the ECRL or maybe the brachioradialis.
So if you have a high ulnar palsy and need to restore that lost distal finger flexion in the ring and the little finger, what's the strategy? How do you get those fingers bending again?
To restore effective FDP power to the little and ring fingers, the most common solution is a side-to-side tenodesis.
Meaning
You suture the paralyzed ring and little FDP tendons directly to the side of the healthy median nerve innervated long finger FDP tendon, usually in the distal forearm.
So they become buddies.
Exactly. This codependence allows the long finger's motor unit to effectively power flexion in the adjacent fingers too. If you need more global grip power, we often transfer something like the ECRL into the FDP tendon mass.
Okay. Now, the high median nerve palsy, arguably the most debilitating single nerve palsy because it knocks out pronation, multiple key flexors, opposition, and sensation. What's the restoration priority here?
It's got to be opposition and pinch. The hand loses all this precision grasp ability. So the strategy focuses intensely on restoring thumb function.
Wow.
For thumb flexion, restoring power to the FPL, a reliable option is transferring the brachioradialis, the BR, to the flexor pollicis longus tendon.
And for opposition, the key thumb movement.
For opposition, we frequently use the extensor indicis proprius, the EIP. It's expendable since the EDC also extends the index finger. The surgical routing here is key, though.
How so?
We typically transfer the EIP tendon around the ulnar side of the wrist, tunneling it subcutaneously towards the thumb MCP joint, or APB insertion.
Why the ulnar side route?
By routing the EIP under the skin on the ulnar side, you naturally create a force vector that closely simulates the oblique pull needed for true thumb opposition. It often works quite well without needing to construct a complex bony or soft tissue pulley at the wrist, which simplifies the surgery and reduces potential complications like bowstringing.
Makes sense. Let's discuss the apocalypse scenario. The combined high median and ulnar palsy. Now you've lost almost everything except the radial innervated muscles.
The BR, ECRB, ECRL, ECU, EIP. That's pretty much all you have left to work with.
This requires massive functional re-engineering.
It's the highest level of logistical complexity, definitely. You have very few available motors and massive functional deficits, leading to the main on-grip, the complete intrinsic minus claw hand across all digits.
Oh, where do you even start?
Reconstruction absolutely requires stabilization before you even think about transfers. Passive stability first.
Like what?
We typically perform an arthrodesis, a fusion, of the thumb MP joint to stabilize pinch. And crucially, we often do a Zancali capsulodesis of the finger MP joints.
Can you elaborate on the Zancali procedure? What does that achieve?
Sure. The Zancali capsulodesis is a really clever surgical maneuver that creates a passive check-crene, a static stabilizer at the MP joint. You can do it by advancing the volar plate distally and proximally, or by using a slip of the FDS tendon.
And the goal?
The goal is to hold the MP joints in slight flexion, maybe around 20-30 degrees. This physically prevents the hyperextension that characterizes the clawing deformity.
And functionally?
Functionally, by preventing that MP hyperextension, it allows the remaining intact extrinsic extensors, like EDC, to effectively extend the interphalangeal joints, the IP joints. It basically turns a non-functional floppy claw into a more stable platform for prehension.
So the stabilization sets the stage, creates a stable platform, and then you begin the motor transfers with the few muscles you have left.
Exactly. The transfers are highly strategic based on what function is deemed most critical for that patient. Often the ECRL gets transferred to the FTP mass to restore some power grip. The BR might go to the FPL for thumb flexion, as we discussed. And often the ECU tendon is extended with a free tendon graft to power the EPB, extensor pollicis brevis, and abductor pollicis longus, APL, for some thumb positioning. It's a multi-stage, maximal effort approach just to achieve stable, minimal, but hopefully functional prehension.
Okay, shifting now from those dynamic deficits caused by nerve injury to structural soft tissue diseases. Let's tackle Dupuytren's contracture, that progressive, proliferative fibrosis that just locks the digits down into flexion.
Right. Dupuytren disease, it begins subtle, usually with nodules in the palm. These are composed primarily of type 3 collagen and myofibroblasts.
And then they progress?
Over time, these nodules progress into characteristic cords, the protendinous cord, the spiral cord, the lateral cord, the retrovascular cord. These cords are what cause the progressive flexion contractures, typically at the MP and PIP joint, sometimes even the DIP.
The cords really dictate the entire operative approach, don't they? And the spiral cord in particular seems to be the one that surgeons, well, fear the most during dissection. Why is it so anatomically treacherous?
It's treacherous because it completely violates the normal protective anatomy of the digit. The spiral cord originates from the protendinous cord, then it spirals around the neurovascular bundle.
Around it?
Yes, spirals around the digital nerve and artery, and then inserts into the lateral digital sheet. The critical surgical pearl here, the thing you must know, is that this cord complex frequently displaces the neurovascular bundle, the digital nerve and artery, superficially and medially.
Towards the midline of the finger.
Exactly.
Yeah.
Superficial and medial, figure 75.4 shows this well. Instead of running safely deep and slightly lateral where you'd expect it.
It's right there, under the skin, pulled centrally by the cord.
Precisely. So if a surgeon approaches that cord superficially without meticulous identification first, especially if they're using techniques like subcutaneous fasciotomy or even just starting open dissection, they risk transecting that neurovascular bundle.
Which means digital ischemia or permanent numbness.
Catastrophic outcome. So knowledge of that specific pathological displacement is absolutely essential for safe dissection in Dupuytren surgery. You have to find the nerve first.
When do we typically decide to intervene surgically, and what does the modern non-operative landscape look like now? It's changed a bit recently.
Intervention surgically is generally warranted when the contracture becomes functionally significant. The usual guidelines are an MP joint contracture exceeding 30 degrees, or a PIP contracture exceeding about 15 degrees, or if the patient just can't put their hand flat on a table.
The tabletop test.
The tabletop test. However, the clinical pearl about timing still stands. Surgery should ideally be delayed until the disease seems more mature, or at least stabilized. Intervening during a highly proliferative angry phase seems to increase the risk of early aggressive recurrence.
Okay, so what are the modern non-operative choices if surgery isn't indicated yet, or if the patient wants to avoid it?
We currently have two main non-operative choices that are widely used. First, There's collagenase Clostridium histolyticum injections, or CCH, brand name Ciaflex.
The enzyme injection.
Right. These enzymes are designed to dissolve the collagen, specifically in the Dupuytren's cord. Clinical trials showed pretty impressive results initially, something like a 77% reduction to 0.5 degrees of contracture in MP joints, and maybe a 40% success rate in PIP joints.
But there were some concerns there revolving around safety and complexity, maybe?
Correct. CCH carries a higher rate of transient complications, bruising, swelling, pain, skin tears during the manipulation phase, especially if you're injecting multiple cords concurrently. The injection requires really careful placement by the surgeon, and then there's a subsequent manipulation session a day or two later to actually break the cord, which can be quite alarming for the patient.
Okay. And the main competitor to CCH is percutaneous needle episiotomy, or PNA.
Right, PNA, sometimes called needle fasciotomy. This technique has gained massive traction, largely thanks to a significant Level 1 study that directly compared PNA and CCH.
And what did that show?
The study showed PNA achieved essentially equivalent or maybe even slightly better results in terms of getting fingers straight. About 79% success for PNA versus 76% for CCH. But critically, PNA achieved this at nearly 1/3 the cost of CCH.
1/3 the cost? That's a huge difference.
Massive difference in cost effectiveness.
So how does the surgeon decide between PNA and CCH then, knowing the numbers are similar but the cost and complexity differ? What's the clinical selection pearl?
Well, PNA is mechanically simpler, it's quicker to perform in the office, and it's significantly cheaper. That makes it often the preferred initial choice for isolated, palpable, tendinous cords causing MP joint contractures. Those are usually straightforward to divide with the needle.
And CCH?
CCH, despite its higher cost and complexity, might still be preferred, or at least considered, for the denser, deeper cords often associated with PIP joint contractures. Those PIP contractures are notoriously difficult to treat effectively with any method, and the enzyme might offer a better chance of release in some of those tougher cases. So it's not really a binary choice. It's more about selecting the right tool for the specific joint and the specific type of cord you're dealing with.
Makes sense. Okay, moving from cord constriction to nerve compression, let's address the undisputed champion of nerve entrapment syndromes, carpal tunnel syndrome, CTS. Can you walk us through the essential diagnostic workup?
Sure. The diagnosis of CTS really relies on integrating three things: the patient's classic symptoms, numbness, tingling in the median nerve distribution, night pain, dropping things, the physical examination findings, and confirmatory electrodiagnostic tests.
The physical exam tests.
Clinically, we rely on provocation tests like Phelan's test flexing the wrist, which has a reported sensitivity of around 0.75, and the Tyndall sign tapping over the nerve, which has a sensitivity maybe around 0.60.
Why are those sensitivity numbers important for the listener, the resident, to internalize? Because
they tell us that these clinical signs, while definitely helpful, are not definitive. A sensitivity of 0.75 for Phelan's means it's positive in 75% of people with CTS, but negative in 25% who still have it.
So they can be falsely negative.
Exactly. They provide a high index of suspicion, but they can be normal, even in very symptomatic patients, or sometimes positive in asymptomatic individuals. True confirmation or objective evidence usually requires the electrodiagnostic studies, nerve conduction velocity, NCV, and electromyography, EMG.
What are the definitive electrodiagnostic findings we're looking for?
We're looking for objective evidence of slowing of nerve conduction across the carpal tunnel. Typically, this is defined by abnormal motor latency greater than 4.5 milliseconds or sensory latency greater than 3.5 milliseconds across the wrist.
But here's the crucial clinical pearl for the resident, right?
Absolutely. While these tests are reliable confirmatory tools when they are positive, they can be entirely normal even when the patient presents with classic debilitating CTS symptoms.
Why is that?
It might be early disease, intermittent compression, or primarily small fiber involvement that doesn't show up well on standard NCVs. The sources cite these tests as being only about 90% sensitive and maybe 60% specific overall. The key takeaway is you must treat the patient, not just the test result. If the story and exam screams CTS, but the EMG and CV is normal, surgery might still be indicated.
Okay. For surgical management, the debate continues, open versus endoscopic carpal tunnel release, ECTR. What do the meta-analyses tell us about the long-term outcomes, and what's the real trade-off?
The long-term data seems pretty conclusive at this point. The outcomes in terms of ultimate pain relief and symptom resolution are largely identical between open and endoscopic techniques. No significant difference after, say, 3 to 6 months.
So the trade-off is all about the early recovery period.
Exactly. It's focused entirely on early recovery.
Yeah.
Endoscopic release does offer potential benefits in the first, say, 12 weeks postoperatively, specifically maybe an earlier return to work and marginally faster recovery of grip strength during that initial window.
But with higher risk, is that the perception?
Yes. The trade-off is a statistically higher, albeit still quite low, risk of transient nerve injury, like the palmar cutaneous branch or even the median nerve itself, or potentially incomplete release of the ligament compared to the traditional open technique.
Why is open potentially safer?
Because with the open technique, the surgeon can meticulously visualize the entire transverse carpal ligament directly and be absolutely certain that the recurrent motor branch of the median nerve, which supplies the thumb muscles, is identified and protected. That direct visualization provides a safety net.
That fear of injuring the recurrent motor branch is often what limits the scope of who's considered a good candidate for endoscopic release.
Right.
When is ECTR absolutely contraindicated?
Yeah, the list of contraindications is critical because having to convert from endoscopic to an open procedure mid-case is never ideal. We generally avoid endoscopic release and revision surgery for recurrent CTS because scar tissue completely obscures the normal anatomy and makes visualization treacherous.
Makes sense. What else?
We also avoid it if there's any suspicion of a space-occupying lesion within the tunnel, like a ganglion cyst or a tumor, that needs to be excised. Or if the patient has had previous tendon surgery within the carpal tunnel.
And a mechanical reason.
Finally, mechanically, a patient who has a severe limitation of wrist extension, maybe from arthritis or previous injury, simply cannot get their wrist into the position needed to safely accommodate the endoscopic instruments and camera cannula. In those cases, open release is mandatory.
All right, let's look just proximal to the wrist now, at median nerve compression in the forearm, what we call pronator syndrome. This can be confusing because the symptoms, like aching pain or paresthesias, can overlap quite a bit with CTS. How do we localize the level of entrapment up there?
Yeah, it can be tricky. We use 3 highly specific resistive tests during the physical exam to try and isolate the entrapment to one of the 3 common sites of compression in the proximal forearm. The key is understanding the anatomy of what you're making the patient resist.
Okay, walk us through those localization tests, linking the physical resistance to this specific anatomical structure that might be compressing the nerve.
All right. The first test aims to localize compression at the pronator teres muscle itself, where the nerve passes between its 2 heads.
How do you test that?
We ask the patient to actively pronate their forearm against the surgeon's resistance. We do this first with the elbow flex to relax the FDS, and then again with the elbow fully extended. If this resisted pronation reproduces their specific forearm pain or paresthesias, the pronator teres muscle is likely the culprit.
Okay, pronator teres, what's the second potential compression point?
The second common site is the fibrous arcade of the flexor digitorum superficialis, FDS, muscle, which the median nerve dives under just distal to the pronator.
And the test for that?
To test this specifically, we ask the patient to resist flexion of their long finger PIP joint, and only the long finger, as the FDS motor units can be independent. Resisting this specific motion causes those FDS muscle fibers in the arcade to tighten down, potentially compressing the nerve if it's compromised at that level.
Makes sense. And the final, most proximal site we check?
That would be the lacertus fibrosus, which is that aponeurotic expansion of the biceps tendon that crosses obliquely over the nerve and vessels in the cubital fossa.
How do you stress that structure?
We test this by asking the patient to resist active elbow flexion and simultaneous forearm supination. This maneuver tightens the lacertus fibrosus across the anterior elbow, potentially compressing the median nerve if that's the primary site of pathology.
So, given that a patient might present with both distal CTS-like symptoms and these proximal pronator syndrome symptoms, how do we establish a surgical priority? Which do you address first?
This requires a really clear decision tree, ideally driven by objective data from the EMG and CV studies. If the patient clearly exhibits both sets of symptoms clinically, we prioritize performing the carpal tunnel release first if the nerve conduction studies confirm positive findings for distal compression at the wrist.
Why distal first if both are positive?
Because relieving the definite distal compression often resolves some or all of the symptoms, and you want to address the most certain pathology first. However, if the nerve conduction studies for CTS are clearly negative distally, despite the symptoms, then we would typically proceed with the proximal decompression of the forearm first. because in that scenario, the proximal compression at the pronator or lacertus fibrosis may actually be the sole cause of the distal symptoms. A double crush phenomenon is less common than proximal causing distal, essentially mimicking CTS. Addressing the proximal issue might resolve everything. #tag beat. Final takeaways. And looking ahead, stepping back and looking at the sheer volume and the granularity of the source material we've covered, it really drives home a singular truth. Hand surgery is the ultimate exercise in functional biomechanical engineering. It really is. The difference between a great outcome and a failure often hinges on synthesizing meticulous anatomical knowledge. Everything from knowing the precise 12 to 15 degree angulation for getting into the wrist arthroscopically, to anticipating exactly how the neurovascular bundle shifts superficially and medially in Dupuytren's disease. And critically, respecting those non-negotiable constraints of tendon amplitude when you're planning transfers. You can't ignore the physics.
We've covered a massive spectrum of intervention today, haven't we? From using a simple Kirschner wire to stabilize a centralized wrist, like we often do in pediatric cases like radial club hand, you see that in technique 80.3.
Right.
All the way to the incredibly detailed multi-muscle logistical planning required for something like a tendon transfer technique 71.13 in a severely paralytic hand. The required consistency and precision across all these vastly different areas, it's just staggering.
It really is. And I think the core takeaway for the learner, for the resident listening, is this. Successful hand reconstruction demands synthesizing those biomechanical constraints. You absolutely must have the amplitude, you need the strength, and you need stable bony support with extremely careful risk mitigation.
Risk mitigation being key.
Absolutely. This involves continuous nerve protection awareness, respecting fluid dynamics during arthroscopy, ensuring your transfers follow the most efficient biomechanical vector possible. The planning process itself, and really adhering to that plan intraoperatively, is arguably just as valuable as the technical execution of the surgery. Plan the work, work the plan.
That detailed planning process often pushes the boundaries of functional creativity, doesn't it? It leads to some of the most profound reconstructive operations in all of orthopedics. We briefly touched on congenital deficiencies earlier, like radial club hand, where severe thumb hypoplasia, maybe type IIB, ETV, or V, is often treated by pellicization, actually moving the index finger over into the thumb position.
Right, creating a functional thumb from the index.
You are deliberately converting a lesser functional digit, the index finger, into the primary functional unit of the hand, a new thumb.
It's the pinnacle of biological reengineering, functionally and cosmetically, when done well. A truly transformative surgery.
Which raises our final provocative thought for you, the learner, to consider. When performing a pellicization, you are literally converting one digital identity into another. Beyond the incredibly complex muscle, bone, and nerve transfers that we've detailed today, which are obviously non-negotiable from a technical standpoint, what other considerations must dominate the surgical and the therapeutic approach, specifically regarding the patient's long-term psychological adaptation and acceptance of this new thumb?
That's a huge point. It's not just about making it work mechanically.
Right. It speaks to the huge, often unquantifiable role of rehabilitation specialists, occupational therapists, psychologists, and patient and family support in translating that mechanical surgical success into true functional and personal acceptance of their reconstructed hand. How do we help them integrate that change? Something to think about.